Welcome to The Pursuit of Health, the podcast on health policy for a free and modern society. Welcome, everyone, to another episode of The Pursuit of Health. I'm your host, Rainer Schur, and joining me back on the show is Colleen Smith and Jared Rhodes. Welcome back.
Hello.
Hi, Ray. Thanks for having us.
So the No Surprises Act is what we're going to be talking about today. It was passed in 2020 and implemented in 2022. And the NSA, for short, was meant to do a very specific thing. It was meant to prevent surprise bills for patients. Now, in many ways, it has achieved preventing these so-called surprise bills, but it's led to all sorts of other problems, which is what we're mainly going to be talking about today. But before getting into all that, let's start by clarifying some of our concepts for our audience. So, what even is a surprise bill?
Yeah, so surprise bill, it's not just you get a bill at home that is more than you expected it to be after you have a doctor's appointment. A surprise bill was this particular thing that was happening to people after they were admitted to the hospital, often because of some emergency. They would then go to the hospital, spend a few nights there, and have doctors who were taking care of them consult with specialists. And so maybe their health insurance was accepted by this hospital. In most cases, it usually was because they would make the choice to go to the hospital emergency department that they knew their insurance would be accepted at, that they had even maybe their primary care doctor was affiliated with that hospital so that they could have some continuity of care after they were admitted. But after being admitted and having these specialists consult, they would just get the specialist who was on call that day. And that specialist may or may not have been uh, in network for their health insurance company. And if the specialist was not in network, ultimately the patient would get a bill for the care that was provided by that specialist. And sometimes that care could include procedures, it could be days and days worth of consulting and helping to co-manage the patient. And so not always an inexpensive bill. And so these kinds of out of network surprise bills from specialists after emergency admissions to the hospital, that's kind of what the Surprise Billing Act was targeting. That's what is meant by the surprise bill.
Right. And before getting into the bill itself, so you mentioned a few times now this idea of being in and out of network, which is what leads to these kinds of surprise bills. Where did that even come from? Like, why is that even a thing? Why isn't everyone in network?
I mean, they've existed for a long time. Although I think it's kind of interesting to point out that there are some alternative models too, right? Like if you think about like the Mayo Clinic or you think about Kaiser Permanente, health maintenance organizations where it really is like an integrated kind of thing where you're buying your insurance and your and the care from one entity. So like that would be those would be a couple of examples of places where there is no kind of distinction between in network and out of network. Just
Mhm.
everybody, you're buying your coverage from that entity, but then you're also going to that hospital, and everybody there works for that entity. And so in those kinds of worlds, it actually doesn't exist.
Mm.
But yeah, for the rest of healthcare, it has been a common thing for really decades. And there's a few different reasons that it came about. One factor that has caused healthcare to kind of lean into this is that health insurance companies are being asked to cover more and more, and we're sort of not really giving them a lot of ways to push back in any way. And so one way that they've come up with is to say, well, we'll choose to only work with certain providers, certain physicians, et cetera, certain facilities. And we'll call them our network, and then we'll have special contracting with them, and then we won't directly work with others. And then by giving them certain a group of people to focus on and contract specially with, well, then they can try to control costs a little bit by doing that, and they have certain prices at which they've agreed to operate with or buy. and that's the in-network one. And now you have that, and that's kind of how you get the in-network providers versus the non-network or out-of-network providers.
Yeah, so within the current system, this in-network, out-of-network phenomenon, it is a kind of a trade between the insurance company and certain providers, right? Like just to explain that a little further. So, in exchange for being in network so that the insurer can advertise like, oh, we have this many providers and um, we will push patients towards certain providers. So like it's beneficial for providers to be in network, right? Because they get all sorts of referrals and things like that. In exchange for that, the provider agrees to a somewhat more competitive price to make it worth it for the insurer, right? Because otherwise, an out-of-network provider, if there were no such distinction, could just charge whatever price they thought was reasonable. And so it's somewhat trying to kind of like facilitate finding the right price, which is the larger context here, right? Because the whole kind of open-ended nature of comprehensive health insurance is that there are no real prices in terms of like pricing signals. There's really no incentive for providers, in other words, to compete on price because if everyone accepts insurance, well, you just charge whatever is the prevailing price, right? Like you're not any better off offering a lower price to the insurer if you can just bill them anyway. And so I think that's how this in and out of network phenomenon should be seen. It's not an ideal like solution, but it's trying to do something which you would have in a real market, right? Because these kind of in and out work network exclusions, you don't really see that in other areas where there's insurance, like home insurance or car insurance, right? Like there's no like car repair mechanic that's in and out of network. You might have certain kinds of integrated systems where like the insurer will like own a particular uh, car repair place where you would end up going. But if you have general insurance, well, you just get like a certain amount and like you have to make do with that.
And then one other aspect of like why are the surprise bills so high when you get them, I think is also maybe important to discuss here. And that's that this idea that insurers often have contracted to never pay more than the highest payer. And so if the rate that you're charging for your cash pay patients or your out of network patients or whatever it is lower than a rate that you've negotiated with any insurance company, those insurance companies will not pay you their negotiated rate. They'll pay you that lower rate. And so what that has resulted in is that the rate that you're initially charged is always really high. And often it's just kind of this made up price that is only intended to be a proof to other insurance companies that someone is paying more than them so that that insurance company will never lowball them on their agreed rate. But because the doctor can't take the risk of not getting paid what he's negotiated to be paid by these insurance companies, he's just charging a really high rate across the board because he knows that's not the rate that anyone will really end up paying him in the end from the insurance companies. And so we have this kind of like made up number. It's really just made up that becomes the kind of usual rate for things. But then that's the surprise bill that you get as the patient when your doctor is out of network.
Yeah, and I think it's also relevant to point out that some of these providers might not even know that they're out of network for a particular patient, right? So it's not like they're going in and like, oh, I'm gonna like make extra money by seeing a patient that's out of that network. They often might not even know. And from the insurer side, they offer a benefit to their in-network providers in exchange for a lower price. And so from their perspective, I can understand that, well, why would they pay an out of network provider the same what they pay their in-network provider? Because then, like, what's the benefit from being in network when you can just charge any insurer without the other aspects of the terms of the agreement for being in network, right? So it's like you're getting all the benefits without like all the obligations of taking on all those other patients, right? So we also have to see it from their perspective, even though it's definitely unfair for the patient. Like I don't think anyone's denying that.
Yeah.
Let's just explain for our audience, given all this, how the No Surprises Act in general was trying to address this problem of surprise bill for patients. Like, how did they try to solve it?
Yeah, I'll jump in. So the main idea here was to create this thing that's an independent dispute resolution. So the IDR is the kind of the main functional feature of the No Surprises Act. And as we mentioned earlier, the it's sort of succeeded in the sense of taking the patient out of it, out of the picture, right? It sort of solves the problem of the bill, this surprise bill going straight to the patient, and you open your mail one day and all of a sudden you've got like a $30,000 bill. Where did that come from, right? And it's very understandable that we want to stop that kind of shock from happening on like regular people, right? They have so little negotiating power in any kind of situation that would arise like that, and so the No Surprises Act shifts the whole issue over to it being a payer versus provider kind of problem now, and let's take the patient out of it, and let's have the payer and the provider go through this independent dispute resolution process, where an arbiter comes in and will identify a price based on, there's some parameters that they have to, I think they have to do like a median price in a geographic area. But those are also just kind of guidelines. Like they actually have the ability to go way outside those too. They'll occasionally name a price that is really, really high. So in that case, let's say the provider, the physician will be happy, or the hospital, the facility, whatever, the provider entity in this whole negotiation. They might be really happy, but the insurance company is feeling, oh well, now we're paying a five times what we normally pay for this procedure. It seems like the IDR process isn't working all that great. um, Again, like it succeeded in getting the sort of the pressure off of the patient, and maybe to that extent we could say there's been some success there, but it doesn't seem to be really making making a great solution and result for the payers and the providers. They're still kind of somewhat unhappy too.
Right. So in theory, when a provider is unhappy with the amount that the insurer offers for an out-of-network service, if
Right.
they're unhappy, they can start to make a claim. And I think at the time they were predicting like, oh, well, this will only be like in the tens of thousands of claims per year. And the idea was that like, okay, well, like the arbiter will try to come to like some fair price. So you've already touched on this a little bit. How's it working out in practice? And we can go through the different parties involved, like the providers, the insurers, and even the employers and patients as well.
Yeah, I mean, from what we've been hearing in reports and in the news and everything, is that the payers have been losing a lot of the cases, or losing from their perspective, and having to pay some almost like surprise bills for them, right? Like really high arbitrated amounts that don't carry a lot of justification or reasoning behind them. That then causes them to turn around and say, well, we've got to raise premiums next year on our general customer base, because these are surprise to us. And so you kind of have, I don't know. You kind of have the problem just sort of being maybe kicked down the road a little bit, right? It's again, it's sort of not in the patient wheelhouse anymore, which is maybe a good thing, but it's still existing at the provider and payer level.
Right. Although the patient might get some surprise premium increases, right? Like, which of course
Yeah.
come more slowly. But if they were paying attention, they would be surprised, right? And so like I would. I think that the patient isn't entirely protected there either. And like
No.
a letter of uh, uh, big employers in America was sent out back in January, like trying to complain to the government that like, hey, we're paying through the nose here with these high bills for our employer-based health insurance. It's not sustainable, and also the amount of claims it's way more claims than was initially anticipated. It turns out a lot of the claims are just on their face ineligible. Like there's certain exemptions for certain claims, for Medicare and Medicaid, it shouldn't be applicable because they have their own system, right? Um, and some of these cases are not even like in out of network cases to begin with. Like the provider in some cases is in network, and it's like uh, I know people love to
Yeah.
hate on insurers, but like you kind of have to feel for the insurer here.
Yeah.
Indeed, the coverage is kind of like pointing the finger a little bit more to the provider in this case, and
Yeah.
a little bit more sympathetic to the insurer. Like they're being taken for a ride.
And there are a couple of cases that are pretty obviously, I mean, I don't know, maybe it is fraud. It's a little bit hard to say. I think it probably needs to be adjudicated before a court, to be honest, and a judge. You know, like there's this story of the breast surgeon who usually charged, I don't know, it was like $12,000 for some sort of plastic surgery, I don't know, breast reduction procedure, which sometimes is covered by insurance because it's a treatment for back pain. And he had been doing it for insured patients for years. And then once this NSA came through, he started specifically reaching out to and advertising his services to patients in a particular insurance company that he was not in network for, and somehow managed to get hundreds of thousands of dollars per back surgery from this insurance company. Like, you know, and I'm saying I do think there are many, many cases where where the doctor has no idea this is going on. But that is a pretty obvious case to me of this guy taking advantage of a system. And I may not be the one to make the decision about whether that's fraud or not, because again, the system is in place, and maybe he is just really smart and took advantage of it. On the other hand, like that's kind of like a little beyond the pale in my opinion, you know. But I think that there's this sense among patients and doctors that the insurance companies are ripping us off, and so why is it a big deal if we rip them off? And you know, I think for most people there's some amount of kind of like, well, but I wouldn't go this far, or I wouldn't go that far, or I wouldn't do that thing. But for some people, maybe that just doesn't exist. I
I mean,
Yeah.
this is a running theme through some of our episodes in the previous episode on Medicaid fraud. Colin, you pointed out that there's all sorts of ways in which the kind of tension between providers and insurers means that providers feel compelled to tell these white lies and massage their charts to make sure that their patient gets care. Even if like getting that care will save the insurer more costs in the long run, right? So there's just like some kind of communication breakdown there, and I think that's playing out here as well. People feel like, well, screw the insurer, they're being hard on us all the time and like not paying us what we think is right, and then like you feel entitled to do the same thing, and like on 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 some end of the spectrum, you can have some sympathy for that, given the way that the incentives have been structured. But then that kind of allows a lot of people to
yeah.
rationalize for themselves like these insane things, what you really need to do is not simply go after like those clearly fraudulent cases. Like in this case, it might not be fraud because there's just simply no rules in place, but it seems fraudulent to me. But you would actually have to like, well, how can we actually improve the communication and kind of value proposition between the different stakeholders? And we'll definitely get to that further on in the episode. First, I think it's also worth pointing out the role of the arbiters here, right? It's they're supposed to be independent. Like, I mean, if you have like a baseball analogy that you would want to use, like they're the umpire, right? And they get some kind of fee for settling these disputes. And one concern that has also been raised in the news with these arbiters is that they might have a bias to side for the provider, because if they side in favor of the provider is more likely to come back with new claims, right? Which means more money for the arbiter. And so there's definitely some perverse incentive going on there. And in one of these articles, I believe it was the New York Times, or maybe it was Stat. Um, one of these arbiters was interviewed and asked like about these perverse incentives, and he said like, "Well, this is how the law is written." And it turns out that he's starting a new trade group where like they're gonna like defend this new cottage industry of arbiters, right? And it's like, well, I mean, like you just see how like this is like kind of like reinforces itself, and I mean,
Yeah.
It's ballooning.
yeah,
People will find a way,
yeah,
to make a dollar off of this kind of broken system. And it's yeah, and even with the arbiters not getting, say, like a percentage cut, it's still it could be a volume business. They could be even just acting in the ways that like juries sometimes do, where you just or you want to stick it to the big corporation and side with the provider or something like that. I mean, you get really sympathetic for one side or the other. Juries don't get paid, but sometimes they come up with some wild awards too, right? And that's I mean that's a whole other issue, but just a sort of an analogous one though, right? Um, when we have a system that's not really based on uh, prices. It just the thing about prices that it gives a real objective kind of anchoring to things. And in so little of healthcare do you have real prices. This is what this is what kind of comes out of that out of that setup. If you have one of the things I think that goes underappreciated about prices is the effect that it has on your own sense um, of like fairness, right? So like if you're getting paid X amount for some procedure, and because you were able to verify by, I don't know, calling up some other place or seeing a sign on the side of the highway, oh, we offer this service. If you're able to triangulate and confirm that, yeah, everybody else that's providing that same service is getting basically the same thing that you are, you're not gonna you're not going to feel taken advantage of. You're not going to try to retaliate. You're not going to try to occasionally name in an arbitration process some huge number because you think you need to make up for something. Like the objectivity of that price is a signal that, okay, no, that is what everybody is. That is the prevailing price here. That's what people are getting. You're not getting more than that. You're not getting less. That's about what you're getting, and so you can go about your professional life and with the feeling of like fairness. You're not worried. Humans are so prone to like the grass is always greener kind of thinking too, right? And like if you're without the ability to like really trust a price that you're getting paid, you might always just sort of automatically think that everybody else is getting paid way more for that, right? Um, it's so I don't know. It's sort of a deeper point about the what prices do for us. It's not
Mhm.
just the market clearing stuff. It's also like the psychological benefit of knowing that, okay, yeah, things are roughly fair the way they are, but we don't really have that, and so
right.
hence this issue.
I mean, I think that whole perspective is what you would need to have had originally to actually have addressed something like surprise billing, that we need to go to a system with clear prices. And really, the way that I see the No Surprises Act is a complete rejection of that perspective. Is that no, like we still want comprehensive health insurance, even though it like obscures the pricing signal. Uh, we'll just have an arbiter like figure out the right price, right? And then yeah, you get these other surprises. Like the you don't get like
Mhm.
a surprise bill for the patient, but you get other surprises along the way, and it's really not working out. And uh, I definitely want to like further develop that alternative perspective. But let's take a very brief look at okay, the NSA is not really working. How are people reacting to these problems in terms of solutions? Like how do they think we should be addressing the problems with the NSA and the independent dispute resolution?
Well, I think it's kind of interesting because so you have this report coming from the American Medical Association that's saying um, that's representing doctors and providers of healthcare in general, and saying the government needs to enforce the arbiter's decisions and force the insurance companies to pay.
Right, because they have their own list of grievances with this process as well, which we haven't really covered. That the insurers are delaying payment and like they're like pushing costs onto patients, and some of that I seems like to be a little bit defensive in light of all these other reports and letters to the government. But some of it is probably also true, and that the fact that some people that put in a claim with the independent dispute resolution might be trying to game the system. Someone who's actually has like a quote unquote proper claim might also be subject to these delayed tactics. And then,
Hmm.
well, that's not fair either.
Right. And then saying that the insurer is pushing the claim off onto the patient, I mean, that is kind of not what the NSA was supposed to do. I
Right.
mean, kind of the great irony of the NSA is that in attempting to protect patients from these surprise bills, they have instead resulted in patients being on the hook paying their premiums, and premiums have gone up. So in the end, the surprise bill, the NSA has really just diffused the cost to everyone, and it's not protecting patients.
Yeah. So it strikes me that all the different stakeholders who have like their unique grievances with the NSA, like really seems no one's really happy with the independent dispute resolution in particular. But almost always what I've seen is people saying like, well, we need better enforcement or we need to reform the arbitration process. Uh, there's really no thinking outside this current model. And I'm not saying that there isn't ways to improve the model, but to the extent that the whole model is kind of a response to the lack of an actual pricing mechanism, it means that if you have some arbiter of some kind, well, it's going to be unfair to someone, right? In that sense, like I don't think there's any kind of reforms that you can do to this process where people actually think it's fair, right? I predict that people are going to continue being unhappy with this process. And for me, it's a bit of an open question of like, well, is the NSA like even salvageable in terms of meeting all these different grievances from different stakeholders? It might be salvageable in the sense of like, well, we can make things a little bit better. But what I would like to explore is what would a better response have been to something like surprise billing than the No Surprises Act, and in particular the independent dispute resolution? And that again goes back to this more general framing, Jared, that you brought in of having an actual pricing mechanism. Like, what kind of reforms could we implement that get us at least a little bit closer to that?
Yeah, well, that's a great question, and you're spot on about the sort of uh, tension between making a a tweak or a fix to the current system, to the No Surprises Act. Is there something that you can achieve in a couple of paragraphs of legislation to fix the No Surprises Act to make it, completely perfect? Probably not. Maybe you can make it slightly better, but it's not going. I don't think you can tweak your way to a total solution on this, which puts us then in the position of saying like, well, what deeper things do you change? And those, of course, are harder to, the deeper the change, the more it affects things positively downstream, and the better the system you can end up with, but the harder it is to make that change, right? To go into this would be a federal thing. So, to go to Washington, D.C. and start putting forth a plan that would really address this would probably also address like a dozen other things, but it would be such a massive omnibus of a plan that it would be hard to sell. But that doesn't mean we shouldn't talk about what some of those ideas are, or at least try to find ways of getting them heard. I mean, there are a couple of sort of basic things that we talked about in other episodes because they do touch on so many themes, like things like using less or reserving insurance more for catastrophic care. That sort of reduces the number of instances where this would even be a concern, right?
It also might reduce the need for having networks to begin with, because the networks, as we said at the beginning, kind of grew out of this need for the insurance company to save money and to manage costs when what they were paying for was becoming more and more and more comprehensive. So if they're not paying for as much care, as much of the routine care, it might be much easier for them to not have a network that they require their enrollees to be part of, when what they're really just paying for is this emergency or higher expense care.
Yep. Right. And another sort of bigger kind of structural thing that you could even talk about too in relation to this problem is what about things that make competitive models more effective at driving out or punishing, let's say, punishing abuses of surprise billing, right? So like one of the reasons, it might seem funny to like cite, I don't know, like repeal of con laws as a solution to surprise billing, but if you think about it, right, like why does your hospital down the road, why are they sort of like able to get away with this kind of this sort of behavior? Like why can they why can they hire a number of providers and set up their facility in such a way that it's so fragmented and has all of those different networks represented in it, and then and not bundle their services up, and not be clear, not be transparent with patients, and so on and so forth. It's well, what's really stopping them? They don't have it's a really patient frustrating thing to be doing what they're doing, right? But where else is the patient going to go, right? And if there was another hospital, 10 miles that way, that wasn't doing this, that would then be something that hospitals and facilities could then compete on. Like we're the ones that won't do this to you,
Mhm.
because we have everybody in house who's agreed to be on the same network, and we even our MRI down the hall isn't set up to be out of network. That actually happens in places, right? You're not even leaving the building. You just go
Yeah.
into like a different wing, and that's out of network for some service. That happens in some of these places. It's set up like that. There are, somebody would say would be able to compete on not offering this kind of experience, and but it's hard to do that because of so many other things like the even like the certificate of needs laws that I mentioned. Again, it seems funny to mention that in the same sentence, but there are connections and through lines between all of these things.
I think another area to look for solutions is not even in like the policy realm, but in the area of where people are trying to offer different insurance products. Like you see this in some cases in employer-based insurance, where you have direct contracting and these things called no network plans, where essentially you get like a lump sum based on like some average or some benchmark for what a particular procedure is expected to cost, and then you take that lump sum and go shopping for it. And you might have different arrangement with the plan of like what happens if you find something cheaper. Like you might be able to keep some of it if you do that. So like I think there's also like just like ways to innovate around this kind of
Right.
problem.
Yeah, or
Well,
your
I'll just
premium might go down, or you might get a refund, or you might,
yeah.
you know,
I'll jump into so Ray, you mentioned that as a almost like a non like going around the system or like a non-policy kind of solution, and it can be in some cases. It could also still be sort of disincentivized though if the bad pol if wrong policy is in effect that let's say that let's say there's a state that doesn't recognize that as a type of insurance, and now all of a sudden like you can't, I don't know, pay for it with pre-tax dollars or something like that. Like even good ideas like that sometimes it's possible to do an end run around, but other times it's not because you're giving up some I don't know, some benefit or some like you know some advantage like a tax advantage or something like that, which makes it's just a different type of barrier. So sometimes those are blocked too.
Yeah, so I definitely think we can spend all day talking about policies and like innovations to get around this problem of surprise billing. Um, but one thing I'd like to return to, and Jared, you brought this up earlier, is kind of like the mentality, the psychology of prices, and like just to contrast that with what the mentality is now. And I think it's made very clear with what's going wrong with the No Surprises Act is that in that kind of context, the mentality towards prices and cost is okay, how can I screw over this stakeholder more? Like if you're the provider, it's for the insurer, and it's for the insurer, it's for the provider and the patient and the employer. It's all about like how can I get the most out of screwing them essentially, right? And that's what it feels like for a lot of people. Now, just contrast that with another attitude towards prices where it forces you to think about the value you're providing, right? Like you become much more internally focused on like, okay, what am I offering? And if I'm not getting like customers like buying my product, maybe it's not valuable enough. Maybe I should like provide something better and like justify my higher price or lower my price. But like all of that kind of thinking on both the provider side, the insurer side, and the patient side in terms of what they value, you just don't have that right now, right? And like that's something that you would have with like a proper pricing signal. And in many ways, that's what we're being robbed of. Like if there's anything that I think we should feel that's unfair about all this, it's that's what we're being robbed of those opportunities with other people.
Well, and I think that's a loss of power for everyone. It's a loss of power for patients. It's a loss of power for providers. It's a loss of power for insurers. It's a loss of power for everyone. We're all stuck in this kind of loop of how do I screw over the insurer that's screwing me over? How do I, and instead of how do I make things better? How do I pay for what I want? To encourage that to continue. And I think this is a little bit of a side topic, but I think kind of there's a sense in which this is one of the pieces of burnout that doctors are feeling, whether they recognize it or not, or that providers are feeling. It's that they're constantly in this kind of negative loop when they could be in a positive loop, like a positive thinking loop. And how do I get around this problem? How do I and often it is an attempt to do the best for their patient, but it's always like how do I trick the provider or the insurance company into doing this thing that I need them to do for my patient? And like that's just so negative.
So, given that there's so many problems with the No Surprises Act, what should we do about it, right? Like, because I suspect that reforms are going to happen, given just the amount of dissatisfaction from all stakeholders. And my view is that if those reforms are still kind of within this framework of thinking of prices of, oh, how do I screw the other stakeholder? Any solution is just going to be uh, making things less bad, not better. And I'm not saying that we shouldn't be pursuing that. I'm sure there's all sorts of ways in which we can rein in the arbiters and make things within the framework fairer, but it wouldn't be the ideal. And so if we actually want to reform the system, the first thing that we have to do is point to another ideal. And when then people still are upset with this whole framework, then we can point to that and argue like, let's reform towards this direction where prices are expressions of value between different stakeholders, not something that you hold over on each other.
I think that's a really good point. It ties it back, and like in so many of our episodes, right? We're talking about how yeah, there are things you can do in the immediate term on something, but it really gets to these underlying things which these themes that come back so frequently, and so I think you encapsulated that nicely right there.
That's an excellent point to end on. We'll leave it at that for now, and I would like to thank our audience, and till next time.
Thank you.
Thank you.
To stay up to date, subscribe to our show from whatever podcast platform you are listening from. To support our show and the Center for Modern Health, you can make a tax-deductible donation at centerformodernhealth.org/support. Thank you for listening.